Hello everyone and welcome to our module on spondyloarthritis. In this video we're going to talk about a group of rare disorders that are called seronegative spondyloarthritis disorders. And the word spondylo means spine and arthritis means joint inflammation, so spondyloarthritis means inflammation of the spine. And then these disorders are called seronegative because they have a negative rheumatoid factor test, and this distinguishes them from rheumatoid arthritis. And so basically the seronegative spondyloarthritis disorders are a family of autoimmune disorders, all with common features, many of them involving the spine. And so in this video we'll go through all four of these conditions I've listed here, which are all examples of seronegative spondyloarthritis. Just a brief word on some terminology. When we say a patient has monoarthritis, that refers to arthritis involving one joint. Oligoarthritis involves 2 to 4 joints, and polyarthritis involves more than 5 joints. And we'll come back to these terms as we talk about these conditions in this video. So before we get into specific types of seronegative spondyloarthritis, let me go over some common features that many of these disorders share. The first is axial spine inflammation, and this means inflammation of the joints of the spine, commonly the sacroiliac or SI joints. Another common feature of these disorders is dactylitis. This refers to inflammation of an entire digit. This is a picture of what it can look like here. You can see this swollen finger here. Commonly, it creates a finding on physical exam called a sausage digit, and you see this in many of the seronegative spondyloarthritis disorders. And then another common feature is enthesitis. This is inflammation of a ligament or tendon attachment to bone, and we'll talk about some of the specific ligaments and tendons that can become inflamed in various disorders later. And then let me make a brief word about HLA-B27. So HLA stands for a human leukocyte antigen, and HLA antigens are antigens, which are basically proteins that make up important cell surface molecules in our body called MHC class I or class II molecules. And these molecules are very important for the normal functioning of our immune system. And we all have genes found on our chromosome 6 that determine our HLA type. Each of us has a specific collection of different HLA antigens based on our genetics. For the MHC class I molecules, there are 3 important genes found on chromosome 6, HLA-A, HLA-B, and HLA-C. And some individuals carry the HLA-B27 subtype of the HLA-B antigen. And this subtype, B27, is common in many spondyloarthritis disorders, and you will read about this in textbooks. 90% of cases of ankylosing spondylitis, which we'll talk about in a minute, are associated with the HLA-B27 antigen. And 50% of psoriatic arthritis cases are also associated with this antigen. Now, most individuals who have the B27 antigen will never develop ankylosing spondylitis, so it's only a minority that actually get one of these disorders, but when patients do have one of these disorders, this antigen is very common. And so for this reason, because you find B27 in many patients who never develop disease, it's really not very useful as a diagnostic test. And in a board question, it's probably going to be a wrong answer, so be very leery of choosing HLA-B27 as the test for someone who you think might have a spondyloarthritis. In actual practice, it's sometimes helpful in equivocal cases, but as I said, it's not very sensitive or specific. Okay, our first specific disorder that we'll discuss is ankylosing spondylitis. This is the classic example of a seronegative spondyloarthritis disorder. And it has the word ankylosing in the name because that comes from ankylosis, which means new bone formation. This occurs in the spine of patients with this condition, and this leads to stiffness of the spine, a major feature of this disorder. Ankylosing spondylitis is more common in males, and it usually occurs at a young age, about 20 to 30 years of age. One of the major clinical features of ankylosing spondylitis is what's known as inflammatory back pain. This occurs in about 75% of patients. So inflammatory back pain develops at a younger age in patients less than 40. This is the typical age range for ankylosing spondylitis. It has a slow, insidious onset, often over weeks or months, and it improves with exercise but does not improve with rest. These are key elements of inflammatory back pain. And then also there's often back pain at night that gets better with awakening or movement, but is worse when the patient is trying to rest or sleep at night. Classically, ankylosing spondylitis involves the sacroiliac joint. This is true of many of the seronegative spondyloarthritis disorders like I mentioned earlier. So these patients develop sacroiliitis, which is inflammation of the SI joint and low back pain. And when you do an x-ray, these patients can have an abnormal SI joint space, and that's from erosion of the joint space due to inflammation. AS patients also classically develop impaired spinal mobility. This is from stiffness of the spine. This can lead to impaired chest wall expansion, and it can in some cases even lead to restrictive lung disease because the spine is so stiff that they aren't able to inflate the lungs normally. Patients with AS also can develop osteoporosis and vertebral fractures related to the bony inflammation. And the classic X-ray finding is called the bamboo spine. This is from calcium deposition due to inflammation in the spine. And I'll show you a picture of what it looks like on the next slide. So this is a cartoon of what a normal spine should look like, and this is what a bamboo spine looks like. It has calcium deposition here along the edges of the joint space. And if you look at these X-ray images on the slide, you can see the joint space here has this white line along it. That's evidence of a bamboo spine. You can also see this straight line here down the spine, further evidence of the bamboo spine, classic X-ray finding in ankylosing spondylitis. As I mentioned earlier, ankylosing spondylitis can lead to enthesitis, which is inflammation of tendons or ligaments. In ankylosing spondylitis, this classically occurs at the insertion of the Achilles tendon. It can also develop in the plantar fascia at the base of the foot. So in many cases, this leads to heel pain, and that's a common presenting feature of patients who have ankylosing spondylitis. Some other clinical features that can occur, you can see dactylitis, like I mentioned before. This is swelling of fingers or toes. This is caused by soft tissue inflammation at tendons. You can also see uveitis, which is inflammation of the uveal layer of the eye. And in some cases, you can see aortitis, which is inflammation of the aorta. And this can sometimes lead to aortic regurgitation, which can lead to a murmur you could hear on physical exam. The diagnosis of ankylosing spondylitis is usually made clinically based on symptoms and exam findings. Also, imaging of the SI joints and spine is usually done, either an X-ray or an MRI. And then most patients have blood test abnormalities like a high SED rate or CRP. This is evidence of systemic inflammation. In terms of treatment, the initial treatment is usually with NSAIDs. This provides pain relief, plus it inhibits the disease process by knocking down inflammation. Some patients also receive TNF inhibitor drugs like adalimumab or infliximab. These are used in more advanced disease cases. And then you should know that DMARDs like methotrexate, which are commonly used in rheumatoid arthritis, are not often used in ankylosing spondylitis. So in a board question, DMARDs like methotrexate are usually going to be the wrong answer. So ankylosing spondylitis is very rare, but for your board exams, you want to know what a classic case looks like so you can recognize it. So it's probably going to be a young male about 25 years of age who has inflammatory back pain, heel pain, and swollen fingers or toes. The ESR and CRP may be elevated. They may tell you the patient is B27 positive. And all of these things represent classic findings in ankylosing spondylitis. And then the treatment is with anti-inflammatory drugs like NSAIDs or anti-TNF antibody drugs like infliximab. Okay, moving on, our next condition we'll talk about is psoriatic arthritis. And as the name implies, this is a form of arthritis that occurs in association with the skin disorder psoriasis. This is a picture of a typical psoriasis skin lesion here on the slide. And in about a third of patients with psoriasis, psoriatic arthritis occurs as well. Patients with psoriatic arthritis develop asymmetric polyarthritis. So multiple joints can be involved, that's why it's called polyarthritis, but it's asymmetric, meaning it's only on one side of the body. And in some cases this resembles rheumatoid arthritis, but rheumatoid arthritis is normally a symmetric condition that affects both sides equally. That's usually not the case for psoriatic arthritis. Besides this, the other features of the arthritis can be similar to RA. There can be things like morning stiffness and joint pain that improves with use. Another distinction of psoriatic arthritis from rheumatoid arthritis is that the distal interphalangeal joints are often involved, and these are usually spared in patients who have RA. And then other features of psoriatic arthritis that sometimes occur are things that go with seronegative spondyloarthritis disorders. So there can be sacroiliitis, there can be dactylitis, and there can be heel pain from enthesitis in some cases. There are nail findings that can occur in psoriasis, and they're more common among patients who have psoriasis complicated by psoriatic arthritis. So one classic feature of the nails in psoriasis is nail pitting. That's shown in this picture on the slide here. You can also see onycholysis, which is separation of the nail from the nail bed. And you can sometimes see subungual hyperkeratosis. This is thickening of the skin and the tissue beneath the nail bed. And this occurs in a little less than half of uncomplicated psoriasis cases, but it occurs in about 90% of cases of psoriasis complicated by psoriatic arthritis. There's a classic imaging finding associated with psoriatic arthritis called the pencil and cup deformity. So as we've already discussed, psoriatic arthritis often involves the distal interphalangeal joints of the fingers. And when this happens, the pencil and cup deformity can form in the DIP joint. This is a cartoon of what it looks like here. The bone begins to insert like a pencil into a cup. And then you can see this finding on this X-ray image as well. Psoriatic arthritis is usually a clinical diagnosis, and the most important thing is to distinguish it from other causes of arthritis, especially with rheumatoid arthritis. Some of the differences between psoriatic arthritis and rheumatoid arthritis are that psoriatic arthritis usually has a negative rheumatoid factor and negative anti-CCP antibodies. These are antibodies associated with rheumatoid arthritis. Also, we've already talked about how only PSA has DIP involvement. Also, only in PSA will you see things like spondyloarthritis or sausage digits or other features of seronegative spondyloarthritis disorders. And then, as I already mentioned, psoriatic arthritis is usually asymmetric, whereas rheumatoid arthritis is usually symmetric. Other things that are important when you're diagnosing psoriatic arthritis is that there should be no preceding infection to suggest reactive arthritis, which we'll talk about in a minute, and there should be no history of inflammatory bowel disease, because in that case it could be inflammatory bowel disease associated arthritis. The treatment for psoriatic arthritis for mild disease without joint damage is NSAIDs. More severe forms are treated similar to rheumatoid arthritis with DMARDs, usually methotrexate, but sometimes alternative drugs like leflunomide. And then biologic drugs like TNF inhibitors are also sometimes used. So inflammatory bowel disease is a topic I discuss in detail in the GI section, but there are two subtypes, Crohn's disease and ulcerative colitis, and both of these conditions are often complicated by arthritis. The arthritis can occur in two patterns. In the so-called type 1 pattern, less than 5 joints are involved. Usually it's large joints like knees, hips, or shoulders, and the symptoms often come and go with flares of the GI disease. In the type 2 pattern, more than 5 joints are usually involved. It often involves the small joints of the hands, and this type of arthritis is often independent of GI disease. And then because this is a form of seronegative spondyloarthritis, you can sometimes see spondylitis or sacroiliitis, and then very rarely you can see enthesitis or dactylitis. And I'll finish this video by talking about reactive arthritis, which is a form of arthritis that develops following infection. That's why it's called reactive. And this is another subtype of autoimmune spondyloarthritis. It usually develops days to weeks following an infection. It can involve a single joint or multiple joints, and sometimes it occurs together with other features like we've been talking about in this video, things like dactylitis or enthesitis. And it's a form of self-limited arthritis that usually resolves within 6 to 12 months. Some of the classic triggering infections for reactive arthritis are first of all GI bacterial infections, like all of the bacteria shown here on this slide. It's also classically triggered by urogenital infections with chlamydia. This can lead to reactive arthritis. Although it can involve a single joint, often reactive arthritis presents as an asymmetric oligoarthritis, usually 1 to 4 weeks after an infection, most commonly involving the lower extremity joints, especially the knees. And then as I mentioned before, you can see enthesitis, dactylitis, and you can also see inflammatory low back pain. And then reactive arthritis can sometimes have clinical features outside of the joints. So sometimes patients develop conjunctivitis. This is an autoimmune process and it can involve the eye. There can also be inflammation of the urethra, that's urethritis. This can lead to dysuria, and some patients develop oral ulcers. And there's an older term called Reiter's syndrome, which involved arthritis, urethritis, and conjunctivitis following infection. And this was basically just a triad of symptoms that you can see in association with reactive arthritis. Reactive arthritis is a clinical diagnosis when arthritis develops following an infection. You have to exclude other conditions. Importantly, patients should have a negative rheumatoid factor and anti-CCP antibodies. These things are usually seen in rheumatoid arthritis. And then the mainstay of treatment is to treat the underlying infection. For the arthritis symptoms, NSAIDs can be used, or intra-articular or systemic glucocorticoids. And then in very rare cases, DMARDs are used, drugs like sulfasalazine and methotrexate. And that concludes our module on seronegative spondyloarthritis.